Today we're very fortunate to have with us Rebecca LeShay. She is a genetic counselor at UCI School of Medicine. She did her undergraduate degree at Bucknell University. She did a master's degree in genetic counseling at the University of North Carolina in Greensboro. She is certified by the American Board of Genetic Counseling. She is a clinical professor at the University of California, Irvine, the Division of Genetic and Genomic Medicine. She is a cancer genetic counselor. She was, before coming here, a cancer genetic counselor at Yale University. She's very well qualified, and she's going to speak to us today about what's new in genetics, in testing, and in treatment for cancer. So please welcome Rebecca LeShay. Rebecca?
Hi, thank you for that introduction. I'm so pleased to be here this morning. I'm really excited to talk to you more about genetics and cancer. I have planned this talk, so hopefully we'll have a few minutes at the end to answer questions. So if you can hold questions till the end, that would be great. But today we're going to be talking a little bit more about how genetics plays a role in screening and diagnosing and treating cancer. Just as a disclaimer, this is not meant to serve as medical advice for anyone in the audience. This is just for educational purposes. Anyone with any specific questions about their own personal or family history should talk to their own healthcare providers. I'm hoping that we'll be able to cover some main genetic risk factors for cancer, as well as be able to discuss the role that it can play in cancer screening and treatment currently. So I'll start with just going over some background in some genetics terms that we're going to be using today, and then we'll talk about some of those different genetic factors and how they play a role. So I wanted to start out with just a moment. I want everyone to take a moment and imagine that they're in this situation where they have a family history and pretty much everyone in the family has had cancer. And so they grow up in a family knowing that they may very well get cancer themselves one day and try to adjust to the fact that they are going to get cancer. They go to their doctor, and their doctor brings up the idea of testing and testing for the family. As it turns out, when they do testing, there is a genetic reason for all these cancers in the family. So we have an explanation, but as it turns out, the person in front of us doesn't have that explanation. So their risks are not increased anymore. They're at general population risks for cancer. This can be really important information when we are treating patients to know, do they have genetic risk factors, or on the flip side, do they not have specific genetic risk factors? How do we follow people? Do they need increased screening or testing or not? But this information can be very complicated. It can be very tricky to figure out how to follow patients, and people don't always get good news. It's not always that there is a reason and you don't have it. Sometimes people do have that reason, or we don't have an explanation, so we don't know how to follow people. So just starting out with some review of some genetics terms. So our bodies are made up of billions of cells. Those are the pieces that make up all of our body. And in each cell is all of our genetic information, which we call DNA. DNA is spelled out with those letters, the A, C, Gs, and Ts. So those 4 letters make up every genetic instruction in our body. And those letters specifically spell out specific genes. So each gene has a name and has a specific function that it is doing in our body. So gene A may be responsible for making sure that our hair color is the color that it is, or our eye color is the color that it is. And all of the DNA is wound up and organized into structures called chromosomes. Another way to think about this is that all of our genome, so all of our DNA, is like a book. It's organized into chapters, which are the chromosomes, and in each chapter, there are individual sentences. Each of them conveys a specific meaning. Those would be the genes, those specific sentences that each tell something specific. But in those sentences, sometimes there are changes that happen in the spelling of those genes. So instead of, for example, ACGT, maybe it says ATGT. So this is a typo in that sentence so that it may not be saying the same thing that it was saying before. So in this example, instead of the gray cat ran down the hall, the gray cat ran down the ball. And so that sentence has now completely changed. These changes are something that happens when we get cancer. So we start with all the DNA we're born with. This is called germline DNA. Over time, we get changes just through living that impact our DNA and can potentially lead to the development of cancer. In sporadic cancer, so cancer that just happens due to chance, typically what happens is we have 2 copies of each gene. We get 1 copy from mom, 1 copy from dad. And over time, due to replication or other factors that change our DNA, we acquire a change in 1 gene. But that's okay, because we have that second copy that's still functioning. So if this is a gene that's preventing cancer, then that other gene is still able to work and help prevent cancer. But if we acquire a change in the other copy, now we don't have any of these copies that are working, and we can get cancer from that. This is normally a process that takes a lot of time. We have a lot of genes, and so the chances that you get 2 changes in the same gene is usually low, but more likely as we get older because we acquire more changes every year that we live. In a hereditary cancer, so a cancer syndrome that someone is born with that puts them at increased risk for cancer, it is not a guarantee that they're going to get cancer. It doesn't mean that they're born with cancer. What it means is they're starting with one of those genes having a change in it. So they're already partway down that path to developing cancer. So now they only have to acquire 1 change in that other gene to develop cancer. And so now this is just much more likely. So they have increased risks to develop cancer and increased risks to have cancer at a younger age. So there are a lot of different genes, and we're not going to talk about all of them, but I just wanted to highlight a couple of the most common ones that people might hear about, especially in the news. So one of the biggest ones that's been in the news lately is hereditary breast and ovarian cancer. There are 2 genes that are associated with this. They are called BRCA1 and BRCA2. These are sometimes also referred to as the BRCA genes. These genes literally stand for breast cancer gene 1 and breast cancer gene 2. And when they're functioning, they help to prevent cancer. However, when someone has a change in these genes, they have increased risks for breast, ovarian, pancreatic, prostate, and male breast cancers. This has been in the news a lot the past 10 years or so because of celebrities like Angelina Jolie and Christina Applegate coming forward and talking about the fact that they carry changes in these genes and talking about their surgeries to remove their breasts and ovaries to reduce their cancer risks. Just for some comparison, the exact numbers aren't that important for this talk, but just for some comparison about what these risks look like. So in general, 1 in 8 women will get breast cancer. That's about a 12% risk. For someone who carries a mutation in a BRCA gene, that chance goes up to 50 to 80% lifetime risk. So it's not a guarantee, but certainly those numbers are much higher than in the general population. The same is true for ovarian cancer. This is a less common cancer in the general population, about 1 or 2 out of 100 women, so 1 to 2%. That can go up as high as 15 to 60% with a mutation. And then other less common genes like male breast cancer, pancreatic cancer, prostate cancer, we can see at increased risk in certain families with this condition. Another condition that's talked about in the news, although not as much with the celebrities, is called Lynch syndrome. And there are 5 different genes that are associated with this condition. And this causes increased risk for a number of different cancers, including the digestive tract, the urinary tract, reproductive tracts. So colon, stomach, small intestine, prostate, uterine, ovarian, a number of different cancers are associated with this condition. And then again, just some increased risks to show you. For this, because there are so many genes, the exact numbers change a lot based on which gene we're thinking about, but there are these increased risks for all these cancers, and so there's a lot of changes that we would make to someone's management if they have these. There are also a lot of other really well-known syndromes that we've been studying for a really long time with significantly increased cancer risks, and we have standard guidelines for how to follow these people. But also, the more we learn about genetics and the more people we test, the more we learn that there are a lot of other genes that we didn't used to know about that can come with cancer risks, and we may not be as clear about what cancers are associated, how high those risks are, or what we do to follow these people. How do we manage those cancer risks? The way these conditions pass in families, most of these pass in such a way that first-degree relatives, so children, brothers, sisters, parents, have a 50% or 1 in 2 chance to potentially have the same condition. So this can be really important information not only for one person, but for the whole family. Some of these can have risks in childhood, not the ones specifically that we've talked about, but some of these can have risks in childhood or can impact reproduction. So some of these conditions, if both parents have these conditions, there can be risks for children to have other genetic conditions. So sometimes people want to know about this when they're planning their families, to know about prenatal testing. But it also is just important for the cancer screening and treatment and risk reduction, and so we'll talk a little bit more about that later. So genetic testing and cancer. There's really 2 types of genetic testing when it comes to cancer. The first one that we're going to talk about is germline testing. And so germline testing is looking at the genetic information that you were born with. So that is what you've had your whole life. There are a number of different red flags that indicate that we may want to test someone, that someone's at an increased risk for one of these conditions. This can include either a personal or a close family history, so a first or second degree relative with a young breast, colon, or uterine cancer. It can be a personal or a close family history of less common cancers in the general population, but that are more likely to be associated with one of these conditions, so ovarian, pancreatic, men with breast cancer, metastatic prostate cancer. It can be a family history of many people with these cancers, even if they're all later onset. Or some people of certain ancestries, like the Ashkenazi Jewish population, have an increased risk to have some of these conditions. Testing is most often done on either a blood sample or a saliva sample. It's rare that we would have to use a more invasive way to get sample. And it is looking at either one, or nowadays it's more common to look at several different genes that are associated with these cancer syndromes, and essentially just going through letter by letter in each of these genes to spell check them and see if there's any changes in any of these genes. When we get results, there are some different types of results that we can get. So just as an example, if we think about that we're proofreading a sentence and we're expecting to find the word color, we can find a lot of different variations of that. We can find that letters are missing. Maybe there's only the letter C. We can find just one letter missing, so C-L-O-R. Or we can find that letters are added. Maybe it's C-O-L-O-U-R. And the question becomes, how do we interpret all these changes? Because not every change in our genetics is harmful. None of us in this room have the exact same genetics. We all have changes, but most of those don't come with cancer risk or other health risks. So how do we know if it's something we need to worry about for cancer? We've tested a lot of people at this point, and so sometimes we find a change that we know is just normal variation, just a normal difference between people. This would be, for example, with that COLOUR. So that word still says color, it's just the British variation on how we spell color. But anyone, if we're reading that, we still know it says color. It doesn't change how we interpret the meaning of that sentence. So that's just a normal difference. But if you're reading a sentence and the word was supposed to be color, but there's only the letter C, that doesn't mean the same thing as color. We may not know what that sentence means anymore. So those types of changes, when we have those in the body, those are sometimes called mutations or pathogenic. Those can impact how that gene is functioning and keep it from being able to do its job. So if that gene normally helps prevent cancer and it's not working, then it's not preventing cancer as well as it should be, and there are increased risks for cancer. Sometimes we find changes and we don't know which of these two categories it is. These are uncertain results, where we haven't seen it before or we haven't seen it enough before, and we don't know what it means. We know from experience that as we test more people, as we do more studies, as we learn more about genetics, we may eventually know what it means. And in the majority of cases, when we learn more, these end up being normal variation. So we treat these as if they are normal variation until proven otherwise, because so many of them do end up being normal variation. When it comes to cancer, there's another model that becomes really important, and this is the model called multifactorial. The way that multifactorial inheritance works is that there is a combination of both genetics and environment, and each contributes a small amount of risk. So we can't always nail down exactly what those changes are. And we like to imagine this with what's called the jar model. So if you imagine that we are all born with a jar, and we're born with a certain amount of marbles in that jar. That's the genetics, that's what we're born with. Throughout our life, marbles get added to this jar through sun exposure, drinking, smoking, and just life. Marbles get added to this jar. If that jar gets full, then we have cancer. That's when we develop cancer. None of us are born with the exact same amount of marbles in that jar. We don't all have the same exact genetic risk factors, but most of us are starting with some amount that is somewhere in that lower range, so all the way on the left. A hereditary cancer is like being born with one giant marble. There's one big identifiable factor that's putting you closer to that top. It doesn't mean that for sure you're going to get to the top, but you're a lot closer than most people in the general population. What we know when we test people is that sometimes we don't find one of those. We don't find a hereditary cancer, but we know they're at increased risk. And the idea is that they're not born with one big identifiable cause, but they probably have many genetic causes that each contribute a small amount of risk, but that all add up to a significant risk. And so they're still starting closer to the top. So they're at increased risk to develop cancer over the general population as well. In the past couple of years, what we've been trying to do is to try to measure those. We have historically not been able to measure those. We just look at a family history and try to assess if people are at increased risk. And that's still what we're doing. But labs are also trying to see, can we start measuring these other genetic factors that might each contribute a little bit of risk, and try to put that together to use something clinically, to give us numbers, to give us management for these patients. Right now, this is still very early, and it's a new technology. Labs tend to be very proprietary, so they each do this a little bit differently and don't always share exactly how they're calculating it. And so at this time, it still is a little bit difficult to manage patients according to this, but it's important information that might help contribute and might be part of that shared decision-making that we were talking about earlier that might help people decide what they want to do, how they want to be followed. So for people who want to learn more about testing, who need testing, or who want to talk about testing, or what testing they need, we always recommend talking with a physician or visiting a genetic counselor. And you can find genetic counselors through the National Society of Genetic Counselors website. There's this big button that says find a genetic counselor, and you can just search for your area, look up cancer genetic counselors to meet with. Genetic counselors are trained healthcare professionals. They have training in genetics as well as counseling. And really their job is to get information from people about their personal and family history to try to assess what types of testing might be recommended and help interpret those results to give management recommendations for them and their families. Specifically in a cancer genetics session, these are the types of questions that someone might be asked. They might be asked about details of their personal history. For women, this is going to include when you started with periods, when you stopped with periods, how many times you were pregnant. It's going to include information about cancer screenings. How often do you get prostate exams? How often do you get mammograms? How often do you get colonoscopies? Have you ever had biopsies? All of this information about your personal history. It's also going to include a detailed 3-generation pedigree. So what that is a detailed 3-generation family history, asking as much information as we can get about the structure of your family, who is living, who has passed away, how old people are, how old they were when they passed away, who had cancer, what type of cancer, and how old they were with cancer. And we're going to try to get as much information about those things that we can. Based on that information, we're able to create an assessment for you, tell you what your chances are. Are you at high risk? Are you at low risk? Are you at moderate risk? Do you meet insurance criteria for testing? Do you meet national criteria for testing? Do we think it would be covered? What testing would be recommended? All of those details about testing, and when those results come in, talking about what those results mean. What do we recommend for you and your relatives? Sometimes the person who comes to us is not the best person to get tested. Sometimes their brother is, or their daughter. Sometimes someone else is the best person to test. I wanted to just take a minute to talk about something that's been coming up a lot lately, which is Medicare fraud. This has become a really big issue, specifically with cancer genetic testing in the past couple of years, where companies are targeting individuals who have Medicare, reaching out to them and telling them that all they need to do is provide a saliva sample and their Medicare ID number, and they'll get free testing. But what happens is a lot of these patients are then presenting to their doctors or a genetic counselor, and the claims that are being filed against Medicare are fraudulent. They're not always good claims, but Medicare has now paid for a test that may not be complete, and so they won't pay for another one. But many of these people need to then get repeat testing because they didn't get the test that they thought they did. Or maybe they didn't need testing at all, but now Medicare has paid $15,000 for a test because of fraudulent claims. So this is becoming a big issue. There have been a number of advisories. It's coming up a lot in the genetic counseling community, and we're trying to report it, but there are these companies just popping up all over the place. So it's really important that if you or anyone you know has Medicare, just being aware, no one except your healthcare providers should be asking for your Medicare ID number and should be offering free genetic testing. So a lot of people will ask, what is the benefit of knowing? Sometimes people say, well, I already have cancer, what's the point of knowing? And there's really a few different benefits of knowing, but this can include screening, early detection, risk reduction, but also that risk to family members. There are a number of different things that we can do based on which cancer someone is at increased risk for. I'm not going to talk about every type of cancer, but I'm just going to talk about a couple of these more common ones. So for breast cancer, there are 3 different options that we would have for someone who's at increased risk for breast cancer. One would be increased and earlier screening. So in addition to an annual mammogram, sometimes these women also get other screens like an ultrasound or an MRI. Instead of starting at 40, sometimes we start in the 20s or 30s. Sometimes we'll do it more than once a year. Some of these women also will take medication. So there's certain medications that can reduce someone's lifetime risk of breast cancer. And some women do choose to have surgery to remove one or both breasts, even if they don't have a cancer diagnosis. When it comes to ovarian cancer, there are fewer effective options. With breast cancer, we know that regardless of screening or surgery, mortality and life expectancy is the same. So both are really good at either reducing chances of cancer or catching an early cancer that's very treatable. That is not the case with ovarian cancer. The screening that we have, which is specific ultrasounds and certain blood work, is not reliable at picking up cancer at an early and treatable stage. By the time we pick up most women, they may already have a late stage 3 or stage 4 cancer. So for women at increased risk, what's usually recommended is that they remove their ovaries and fallopian tubes. This is not done at 20 or even 30 in most cases. It's usually when women are already in menopause or getting closer to menopause, because we don't want to take out the ovaries too early because those are important for heart and bone health for women. So we have to weigh those risks and those benefits to decide when it's time to take out the ovaries for a woman. And then the last cancer that I'm going to touch on is colon cancer. So most people might be familiar with a colonoscopy. It's where they use the scope to look at the whole colon, and if they see any growths, called polyps, they would remove them. So it's one of the few cancer screenings that also reduces risk for cancer, because when those growths are removed, you're removing something that might have turned cancerous if you left it in. So for people at increased risk for colon cancer, we can do colonoscopies more often and at earlier ages, which helps not only catch early cancers, but potentially decrease risk of cancer as well. There are also certain medications, like aspirin, that have been shown to help reduce risk of colon cancer in some of these high-risk populations. And in the most severe forms, we do remove part or all of the colon to help reduce that risk. The other type of testing, so we talked a lot about germline testing, and I'm only briefly going to touch on tumor testing because it's a very complicated topic. It could take many hours just in itself, but I just wanted to touch on this. So this is testing that is looking specifically at genetics in a tumor. These may or may not be the same as what you were born with. Because if you think back to early in the talk, I talked about we get changes throughout our life and these can lead to cancer development. So sometimes these changes are only in the tumor. One of the main goals of doing this is trying to figure out if there are targeted treatments that we can use to treat these cancers. And in some cases, we don't find anything, but in some cases we do. So this is often done when someone is either first diagnosed or if they have a recurrence of their cancer. So their cancer comes back. They can take that tumor and they can look for different genetic changes. Sometimes this can give us information about prognosis. Sometimes it can tell us, are there increased risks for this to come back, for it to not work with certain treatments? Are other treatments better? Sometimes we get no information. Sometimes it's not particularly helpful, but it can be useful, and it's not something that we only do once in some cases. Germline testing, what we're born with, you usually only do once, because you're only born with one set of genetics that doesn't really change. With tumors, our tumors are constantly changing. So if you have a cancer and then 5 years it comes back, the genetics in that tumor might be very different than it was 5 years ago. And so they may need to repeat these tests to know what to do for treatment. This is applied to a number of different cancers. It's common in particular in lung cancer. There are certain tests that they do on essentially everyone in some hospitals. This is not only important for approved medications, but some of these can also qualify people for research trials, research studies. The last topic that I wanted to just touch on is direct-to-consumer testing. And these boxes might look familiar to people. Direct-to-consumer testing is testing that people order without the involvement of their normal healthcare providers. So this includes the common tests 23andMe, Ancestry, that are all over. Direct-to-consumer testing is really good at certain specific things. It is really good at detecting your ancestry at the continental level. So for example, if it tells you you are European, it's pretty accurate that you're probably European. When it starts getting to the specific countries, 30% British Isles, 20% French, that part is not as accurate. It's highly variable between companies and changes over the years. It can be a lot of fun. It can tell you about fun traits, and it can help you connect with relatives if that's something that someone's looking for. On the flip side, you can find out about relatives you didn't know you had. For example, there are a lot of studies of people finding out they have half-siblings that they didn't know about. Sometimes their parents didn't even know about it. So there's a lot of stories like that nowadays. From a healthcare side, the bigger risk is these healthcare reports. So some labs offer healthcare reports directly from the lab. Some people download the information from their DNA and upload it into other softwares that give them healthcare information. But what's risky with this is that these are not clinical graded tests. The information from them is not the same as a clinical test. They are not right 100% of the time. There are clinical labs that are now doing direct-to-consumer testing, so clinical grade labs that you can now order both genetic or non-genetic tests directly without your doctor. But what's really important is if someone's ordering their own testing, that they make sure that if they're going to make any changes to management, that they talk to their doctor, they involve someone with special training in genetics to help interpret those results and determine if follow-up testing is needed to confirm a result. It's also important that when you're consenting, you really read that fine print of what you're getting testing for, what you're getting results on, because there are sometimes results that people may or may not want that may come back. For example, some people find out unexpectedly that they have an increased risk for Alzheimer's, and they didn't know that they were even going to be tested for that or get that result, and they weren't ready for it. So just to end, I put in just a couple of cases to help tie all this information together and hopefully just solidify how it all can apply to a case, and then I'll open it up to questions. So this first case is a 35-year-old woman diagnosed with breast cancer at 35. She comes in and she has a significant family history of cancer. Her dad had male breast cancer, and her dad's mom had died of ovarian cancer. Based on this family history, we would say that there are a lot of red flags. This is a high-risk family for a hereditary cancer, and this is definitely someone who might want to consider testing because it might change what she wants to do about her current breast cancer. And it was not surprising, but she came back with a mutation in one of these genes, a BRCA2 mutation. So she has hereditary breast and ovarian cancer syndrome. So for her management, we would treat her breast cancer. She may choose to do a double mastectomy. So she may choose to have both breasts removed based on this information because she's at increased risk for future breast cancers. She would want to think about when she's going to have her ovaries removed. In the meantime, she may undergo ovarian cancer screening, and all of her close relatives now would need testing, except for minors. This is not a pediatric onset condition, so children are not expected to have cancer. So we do not test people under 18 for this condition usually. This next condition or case is a woman. She was found to have a change on her direct-to-consumer test, and no one will take her seriously. No one will do anything for her for testing, and she's really worried about her daughter. She's really worried that they need testing so that they can get their appropriate care. There's no family history of cancer. She's never had cancer. And we know that up to 40% of these findings on direct-to-consumer tests are false positives. So we need to confirm this result in a clinical lab. As it turns out, she tests negative. So this is actually really good news for her and her family because she's at general population risk for cancer. So she needs annual mammograms, colonoscopies at least every 10 years, but we don't need to do any testing for her relatives. This last case is an example of someone diagnosed with ovarian cancer. There's no significant family history. Her germline testing was negative, so we didn't find a hereditary reason for her cancer, but we did find something in her tumor. So we found a change in her tumor that made her eligible for special treatment for her ovarian cancer and some different research trials. So we're not testing any of her relatives. This is only in her tumor, but this really gave her some new options for treatment of her cancer. All right, and so that's all that I had prepared, and so I'm happy to answer any questions that anyone has. Yes?
Can you go back to the Lynch syndrome slide and what was that testing for?
So the Lynch syndrome slide. So what was this testing for? So Lynch syndrome is a condition with a number of different genes that are associated with a number of cancers, specifically colon, uterine, ovarian, stomach, intestine, and other cancers in the urinary, digestive, and reproductive tracts. Yes. Those are good questions. So the first question was, what does this testing cost? Most cases, if someone meets criteria for testing, many people will get this covered in full or at least in part. Without any insurance coverage, it can be thousands of dollars, although many labs are offering cash pay for several hundred. So people that don't meet insurance criteria or their insurance is going to still be very expensive, many labs are offering this test for maybe $300. In terms of the second question was about the length of time from getting results to implementing a treatment. That one's a harder one to answer because it's so variable. There are times when we get a result and we know immediately that we're going to use a different chemotherapy or a different surgical technique. So we used to, at my last job in cancer, we used to see patients for treatment decision making. So they immediately were diagnosed. They came to see us before they had any of that, during their initial diagnostic workup, because it was going to change something immediately. In some cases, certain medications can only be used once a certain other standard of care has failed. So for some of them, they have to try a first treatment, and if that doesn't work, then they can use a special treatment. And then there's always the possibility that we may not have something known right now, but that months or years down the line, we may eventually learn of a treatment that could be implemented in the future. Mm-hmm. Yes.
Are you seeing an increase in the lynch risk with a specific race at all, or are they not into it enough to know yet?
Yeah, so the question was if we're seeing Lynch syndrome more with a specific race. And I'm trying to think, not in particular. There are certain specific changes in certain genes that we see more often in certain populations, but in general, this is something that we see in 1 out of every maybe 300 or 400 people in the general population would have this, and depending on the details of someone's colon cancer, then they would then be at increased risk. Yeah. Yeah, that's a good question. So the question was about, as we get older, we're already having changes to our germline, so would it be less accurate than if we were younger? And so really what we find is that for the most part, that's not so much of an issue because those changes that we acquire with age are usually in very isolated cells or parts of our body. So when we're taking a big sample and looking at many cells, then the chance that that becomes relevant in the testing or even shows up in the testing is usually very small. There are rare cases where we get some uncertain results that we think might be related to someone's cancer or aging or other factors, but it's really a pretty small proportion of cases. So the question was about the threshold of how many changes and how many cells before we start getting worried that cancer might develop. And it's a difficult question to answer. On average, you're right that it's not just one change in one cell that usually then leads to cancer right then. It's usually a slow growing process that one change happens and then that cell divides, and now a bunch of those surrounding cells have that change. And now some of them start acquiring other changes, and on average, cancers do have many changes, not just 1 or 2, but usually it's thought at least 5 or 6 different genetic changes that might be driving that cancer. And then what happens is it starts in just a couple of cells, and those cells start dividing uncontrollably. So normally our body has checkpoints to keep our cells from dividing when it's not needed. These start bypassing those checkpoints and start growing uncontrollably. And then you suddenly have a whole mass of cells that can't control itself. And so it's hard to give an exact number, like it's this many cells, this many changes, but you're right, it's not just one cell, one change, it's a slow growing process. Yeah, so the question was about shared decision making and how much information patients are given, if they're given enough information to make decisions. And I think the idea between shared decision making isn't necessarily just to take pressure off of the physician to reduce liability. I think it is this idea of there's not always one right or wrong, especially when it comes to genetics. There are sometimes very complicated situations where there are multiple options. So for example, with increased risk for breast cancer, like I said, whether you do surgery or increased screening, the life expectancy is the same. So that's really up to the patient, what they want to do. And so in genetic counseling, we use a practice called non-directiveness, where we do not just tell patients exactly what to do. We do not force them to even have genetic testing if they don't want to. We give them information and try to work with them to see what are their goals and what is the best decision for them. You're right that we only get an hour with patients. They can't know everything there is to know about cancer or about genetics, but the hope is to give them enough information to feel okay with that decision, at least for the time being, and we can always revisit it if we need to in the future. The next time they see their doctor, it's not just a one and done decision. Some of these are ongoing decisions. And it's not going to stop providers from making recommendations if there are recommendations.
And also the importance of asking for a second opinion if you're uncomfortable.
Yeah, exactly. And so the comment was also asking for second opinions if you're uncomfortable. And that's exactly right. The question was about studies looking at the environmental role of development of cancer, how that impacts our genes. And yes, there are things that we know impact our genes. And In some cases, it's a very obvious association. So sun damages our skin cells and can lead to skin cancer. And so then targeting that is reducing sun exposure using protective clothing, sunscreens. Some others are less clear. So certain areas with high levels of pesticides or certain chemicals in the water we know are these hot spots where a lot of people in this area start developing cancers. They may not be the same types of cancers even. And those are sometimes trickier because they're a much bigger scale to affect change. But yes, there is some research in that, and I think the hope is certainly to try to reduce that environmental component, but I'm just not sure that there's easy answers on how to do that.
Does the genetic counseling also, and cancer screening also include those factors? You mostly mentioned hereditary.
Yeah, so the question was about if genetic counseling also includes those factors. And yes, when there are modifiable factors, those are things that are sometimes brought up. So for example, for people that are at increased risk for pancreatic screening, for pancreatic cancer, we know that smoking is a very big risk factor for pancreatic cancer. We strongly encourage refraining from smoking in those patients. Also, cancers like breast and colon cancer, obesity, and lack of exercise, poor diet are significant risk factors. So those are things that people can potentially change. The other factors, such as something in the water or other exposures, those are a little harder to pinpoint and change, but there are certain things that people can do to reduce lifetime risks. So the question was about the status of research on tumor testing to help direct targeted chemotherapies or immunotherapies. And in some cancers, it's very advanced. So for example, in certain colon cancers and ovarian cancers, lung cancers, we have some good options for immunotherapy or chemotherapies. In some other cancers, it's not as well studied, or we don't really know how to use those results just yet. We don't know if a genetic change that we find in an ovarian cancer cell is the same. Does it respond the same way if that same genetic change is found in a breast cancer cell or some other cell? We don't always know that just yet. So it's very variable. Some we have a lot of research, some we have little to no research. So the question was about that 23andMe and Ancestry are pretty good about the ethnicity determination. If he had testing with a third lab, would that be the same or different with the healthcare based on those other two labs? So in terms of the ethnicity part, at the continental level, you're likely to get the same result in all three labs. So if you're European, you're likely to get European, but the exact breakdown of countries is likely to be different. The exact percentages, the exact countries, and anything below like a 5% threshold is within margin of error. So for example, a lot of people come to me and they say, I have 1% African. And I say, well, many of us probably do, but that's within the standard margin of error. It doesn't mean that you have a strong ancestral base in the recent history from Africa necessarily. In terms of the healthcare reports, those can vary a lot between the different companies. There's a lot of different platforms, and some of them are known that they have really high false positive rates at certain areas that others don't have the same high false positive rate. So you're likely to get different results because that's not really the purpose of the test. They're not specifically looking for those changes. So the question was about MIT studies to change genetics to reduce chances of getting cancer. And I'm actually not familiar with those specific studies, so I'm not sure who is collaborating on that, who's doing that. And so I'm not sure if it's available on the West Coast. Yeah.
Has anyone successfully changed the BRCA gene?
So the question was, has anyone successfully changed the BRCA gene? I am not familiar with anyone who has purposefully changed the BRCA gene. There is a phenomenon in the body where you can see them sometimes in tumors revert to being normal, but that was not human directed. The question was about BRCA1 and 2, if it's only for breast cancer or other cancers. So there's two answers here. So looking at the BRCA genes tells you about not only potential breast cancer risks, but also ovarian, prostate, some other risks. However, when we're doing testing nowadays, we often test for many different genes associated with risks for those cancers. So most people have more than 10 genes looked at nowadays.
So if I had the BRCA1 and 2 and I was negative, and tested for all those others?
So if you had BRCA1 and 2 and it was negative, it depends on what was ordered and when. Some people, depending on when they have testing, need updated testing because they may not have been tested for what we can offer now. And it's not testing to see if you have cancer, it just looks to see if you have a genetic reason that increases your risk for cancer. Yep.
So the report would say what was tested?
Correct, the report would say what was tested on it, yes. This is a question about when insurance pays for testing, are they expecting to see those results and use it to control treatment now or in the future? So when insurance covers testing, they may be privy to the results if you are using them to justify some of the treatment that you're doing. So there are federal and state laws in place that insurance is not supposed to discriminate against you based on your genetic status. So for example, they can't just say, oh, you have a BRCA mutation, we're not going to cover you for healthcare anymore. They cannot do that. But if, for example, someone has an increased risk for cancer and we're trying to justify why they need additional screenings beyond the general population, they're going to ask for documentation of why we need that. And they can use that to say, oh, BRCA mutation, yes, we do cover that in this case then, and so then they would cover those treatments potentially. Those same protections for healthcare insurance do not apply to other insurances, so life insurance, long-term disability insurances. Like a life insurance policy can decline to cover someone if they have these genetic changes. Yeah. All right, thank you all so much for having me.